Okay. Good morning, everyone. So this is a topic pretty close to all our hearts, and that is I'll be talking on correlation of risk factors and adjuvant therapy in the era of secondary enucleation for retinoblastoma. So we all know that retinoblastoma has a significant incidence and high fatality rate if untreated. And in Asian countries like ours, delay in diagnosis leads to advanced disease at presentation. Lack of access to advanced medical facilities is there, and we have absence of standard management protocols at all the centers. We have seen earlier that secondary enucleation so treatment in retinoblastoma advanced cases led to a 44%, 43% of eye salvage, which is a significant number. But what about metastasis? What about how to timely diagnose retinoblastoma? Is there a way to identify the risk factors? And is clinical identification possible? So we went on to study that. So here is a case, 2.5-year-old child presented with secondary glaucoma, and she was treated with neoadjuvant chemotherapy, 6 cycles, and residual tumor was seen overlying the optic nerve head and the macula. On enucleation, there was still thickness was there in optic nerve, there was involvement, and histopathologically proved that optic nerve invasion was present. So we were able to put it all together. And we saw that what about studying the clinical risk factors and histopathological risk factors and finding a correlation. So let's see what would the clinical risk factors be. Iris neovascularization, secondary glaucoma, sterile orbital inflammation, AC seeds, hyphema, and ophthalmos. These are the 6 possible clinical risk factors, and we put them all together. At the same time, we put together iris infiltration, choroidal invasion, retrolaminar involvement, optic nerve resected end involvement, here the meningeal involvement is seen, lamellar scleral involvement, and extrascleral spread. So we put together histopathological risk factors. But what about a correlation between the two? What about correlating the clinical risk factors and histopathological risk factors? Is it possible? So we put them together. And what we found was that, so we put them together by studying 920 enucleated eyes. We included all the cases undergoing secondary enucleation, and we ruled out the baseline metastasis patients, and loss to follow-up were also taken out. So we saw that secondary enucleation was was done in 44% cases, and clinical risk factors were present in 60%, and histopathological risk factors were present in 30%. Most commonly, the histopathological risk factors were choroidal invasion, and optic nerve extension was also seen in 22% cases. This is not a small number. And out of these cases, clinical risk factors were present in iris, like being iris neovascularization is common, secondary glaucoma being common, sterile orbital inflammation, along with AC seeds, hyphema, and ophthalmos. And we saw that there was a common point, and that was that risk factors were present clinically and histopathologically in 22% cases. And we went down finding a correlation, and we saw that the p-value was significant. So when we see a clinical risk factors, we have a high chance of getting a histopathological risk factors despite neoadjuvant chemotherapy. We assessed all the histopathological risk factors and went on to study the AJCC staging of those patients only. And we saw that the most common, the metastasis-related death was seen in the radiological optic nerve extension proven patients, or the ones which presented with proptosis and orbital mass at clinical presentation. Previous studies have been done on primary enucleation and secondary enucleation individually. However, a correlation of the secondary enucleation eye is a correlation of clinical risk factors and histopathological risk factors has been done now. And we have seen that our patients received neoadjuvant chemotherapy in all cases, adjuvant chemotherapy in all cases, and we saw a 99% life salvage in all our patients. And the ones which had histopathological risk factors had 95% life salvage. So to conclude, adjuvant chemotherapy was given in all, radiotherapy was additionally given in 8% cases, clinical risk factors and histopathological risk factors were common in 22% cases, and it is a correlation. And at a follow-up of nearly 10 to 12 years, we have seen that life salvage was achieved in 99% cases with 95% in the histopathological risk factors patients. So this does help in predicting metastasis and facilitating life salvage. So that's the correlation we wanted to establish, and these are our references. Thank you.
All right. So thank you. That was really a very large series and great work there. I have one question. This series included cases that underwent a secondary enucleation.
Yes, ma'am.
So that means that they were all treated with some form of systemic chemotherapy,
Yes, ma'am.
I assume. So systemic chemotherapy prior to enucleation is known to downstage the histopathology. My question would be, how did you take into account the histopathological risk factors when you were considering these eyes?
Okay, ma'am. Thank you for the question, ma'am. You are right that it downstages the histopathological risk factors. That's why we did not even assess separately the staging of pathologically, like, the PTNM staging of histopathological risk factors has not been commented on, as we cannot comment on the same. However, the histopathological risk factors in primary enucleation have shown that there are studies where the histopathological risk factors are based on that. However, in secondary enucleation, in our cases, we do have to comment on certain risk factors which are present. Like, for example, here I've mentioned extrascleral invasion is present, choroidal invasion is present. So most common was choroidal invasion. The second part, that was optic nerve extension. So we have correlated it on the basis. Downstaging is definitely kept in mind, ma'am.
Thank you. And you might be having cases in this cohort where children might have received, maybe 6 cycles of chemotherapy, and then again on histopathology, you had high-risk features. So how did you go on with your protocol of adjuvant therapy in such cases?
Okay, ma'am. All the patients where we saw histopathological risk factors, adjuvant chemotherapy of 6 cycles was given in all the cases. And along with radiotherapy that I've mentioned in 10 cases where we had expected optic nerve extension beyond, or if there was any intracranial extension residue which was shown on radiology.
Okay, thank you.
Thank you,
Any
ma'am.
questions? Yeah. No, you can ask, no problem.
I don't have a case on this. Interested in knowing.
Yeah.
The clinical risk factors that you assessed, was it at presentation?
At
or
presentation.
At presentation after 6 chemocycles?
No, sir. At presentation. Yeah. At
So at
presentation.
initial presentation?
Yes.
And then, was there a subset of patients who after chemo did not have histopathological risk factors?
Yes, sir.
And then what was the treatment for them based on?
The patients who did not have histopathological risk factors after giving the initial set of chemotherapy, they were not treated with further adjuvant chemotherapy.
So I think
They
that
were
was the
kept
point
on a
Ma'am was
follow-up.
alluding to, because if they may have had risk factors,
Right.
that would have been downstaged by that. So
Right.
had the child had been enucleated initially, histopath would have shown that the child needed adjuvant chemo. But since we've already given adjuvant chemo, there is
That's
some
right.
subset, and possibly things like maybe scleral invasion, which would then additionally necessitate radiation, would not show up in enucleation after chemo.
That's right, sir. That's
Yeah.
why that at the long follow-up also, those patients were kept on regular follow-up, that there was no metastasis despite that. That's the point that you're trying to.
Yeah, masking is a concern. So any patient who we normally treat with chemotherapy and then subject them to enucleation, regardless of what the histopathology is after enucleation, we tend to continue with the recommended protocol for chemotherapy in such cases.
Thank you.
Okay, thank you.